Hello everyone, I'm Dr. Katie Leung from Rheumatology of Singapore General Hospital. Today, I'm giving you a 10-minute talk on psoriatic arthritis. The learning objective today is to recognize psoriatic arthritis, understand the comorbidities, and aware the treatment strategies. Psoriatic arthritis is a distinct entity. Previously, we recognized it as a form of rheumatoid arthritis and is a close relative to spondyloarthritis. But now we recognize it as a distinct entity which has different pathogenesis, different phenotypes, different response to treatment, and different outcome measures and prognosis. It's not a benign disease. It results in joint damage, disability, and poor quality of life. And it also increases in cardiovascular comorbidities and early mortality. The skin disease of psoriatic arthritis, which is the psoriasis, has also a lot of negative impact on people's quality of life. Epidemiology-wise, it's not a very common disease. It ranges from 20 to 420 per 100,000 people. And in Asia, the data is very limited. In Asia and Japan, the prevalence reported is much lower than Caucasian countries. In Singapore, we know that Indian, as compared to Chinese and Malay, is more common. Among people who have psoriasis, around 30% of them may develop psoriatic arthritis. Psoriatic arthritis is a diversity of clinical manifestation. They can affect the joints, including the peripheral joints and spine. They can affect the entheses, we call it enthesitis. They can affect the finger, the whole digit, we call it dactylitis. They have skin manifestation and nail manifestation. They affect the quality of life, physical function, and causing disability. They have comorbidities and cardiovascular burden. Now we identify psoriatic arthritis via the Casper criteria, which essentially describe inflammatory changes in the articular joints, including the peripheral joint, spine, or the tendon. And in addition to that, we need some more points to be classified as psoriatic arthritis. Say, for example, the psoriasis is scored 2 points. If there is no current psoriasis, then personal history of psoriasis or family history of psoriasis counts. And if there is psoriatic nail lesion, negative rheumatoid factor test, dactylitis, or some radiographic change, then we'll classify people into psoriatic arthritis. Of course, the main thing is that classification criteria are developed for the purpose of clinical trials. The most important thing is to recognize the specific features of psoriatic arthritis. This is a biomarker of psoriatic arthritis, which is psoriasis itself. It is described as a well-demarcated erythematous lesion. They appear thick and also scaly. Typically, they are not found in the very prominent areas. They are under the hairline. They are under the shin. They are sometimes at the back, only a gutty patch, and they can be pustular and having pustule like this one in the palm. The key thing is that if you don't look out for it, you may not find it. This is the nail of the psoriasis. Basically, divide into matrix disease and nail-back disease. As if you look into this diagram, if there is matrix illness, then when the nail grow out of it, and then some part of the cell is not healthy and falls off, it becomes a pitting. If there is a lot of pitting, then we call it a crumbling. Of course, if the cell is not healthy, but it's not in the top layer, that it's trapped in between, it becomes something whitish. We call it nucleolycia. Whereas nail bed lesion is overgrowth of the nail bed, causing hyperkeratosis here, and so much so that some of the patient will have lifting up the nail from the nail bed. We call it onycholysis. This is a typical example of the pitting. Sometimes you will need to see it under the reflection of the light. And you can see also some of the nucleolycia in this picture too. This is hyperkeratosis and onycholysis. The psoriatic peripheral joint disease is very interesting. They are asymmetrical as compared to the rheumatoid counterpart. They affect the lower limbs more. They affect the distal interphalangeal joint. And as if there are two processes happening in the same finger or same hand. They have the joint erosion where the joint is disappearing. So much so that most severe form, we call it osteolysis. The whole digit is disappearing. And at the same time, you have sclerosis. You have the ankylosis that the joint is joined together. This happens in one hand, even on one finger. Enthesitis describes the insertion site of the tendon towards the bone. When there is inflammation at that site, we call it enthesitis. You can look into this picture, you will recognize the enthesitis is inflamed. And then you cannot see the Achilles tendon, the contour, and there is a lot of swelling over that area. Another hallmark of psoriatic arthritis is the dactylitis, which describes the fusiform swelling of the entire digit. Sometimes we can measure the circumference of the digit. If it is 10% more than the circumference of the same digit on the other side, we call it dactylitis. On MRI, we know that this dactylitis is not just limited to the joint, but the whole digit, including the tendon, synovium, and subcutaneous tissue. So we count it as an active joint in psoriatic arthritis because it's associated with underlying joint deformity over time. The spine involvement in psoriatic arthritis is less well studied. The prevalence varies between studies due to the differences in the definition of spinal involvement. And in some people, particularly Chinese, the spine involvement are relatively asymptomatic. Psoriatic arthritis is associated with many comorbidities, including diabetes, hyperlipidemia, central obesity, hyperuricemia. And then they are associated with atherosclerosis and early mortality due to cardiovascular disease. Treatment strategy is important. Now we emphasize early diagnosis, early effective treatment, and treating the disease to a certain target. This is the GRAPPA guideline recommendation for treatment. We treat according to the domain of psoriatic arthritis like peripheral joint, skin, axial disease, dactylitis, and enthesitis. We also go according to the level of evidence. For peripheral arthritis and skin disease, the traditional DMARDs, disease-modifying agent, perhaps have a little bit of evidence, but most of these domains, you may require anti-tumor necrosis factor for better treatment. We treat to a target so that they are in minimal disease. This minimal disease criteria is associated with better outcome and better radiographic outcome in long term. Coming to the summary, I hope that you can recognize psoriatic arthritis and they are distinct disease entity. They have a diversity of manifestation, including the skin and nail, peripheral joint, enthesitis, dactylitis, and spine. They are associated with joint damage, disability, and poor quality of life. They have high comorbidities and increase in cardiovascular risk. We need early diagnosis. We need a treat-to-target strategy. Thank you very much for joining me in discussing psoriatic arthritis.